There are three main reasons why we might cancel a patient's egg retrieval cycle before they have the chance to get to an egg retrieval.
My book, The Lucky Egg, covers all the snags one can hit while doing an egg retrieval cycle and how to troubleshoot various problems such as low or no response to stimulation.
The first and most obvious is that there is no response. Sometimes, especially with patients who have very diminished ovarian reserve, they just may be completely unresponsive. Despite giving high doses of medication and using aggressive protocols, if you have a very low egg count, sometimes it can make it really hard. It's almost like the ovaries are a little bit resistant to those signals, and sometimes we just don't see a rise in the estrogen level and we don't see any follicles growing. Now, this doesn't mean that you won't have a response in subsequent cycles. It means you're at very high risk of this happening again. But I have had cases where I've changed the protocol, made certain adjustments to the plan, and in the subsequent cycle, we were able to get a better response. But typically, this is going to happen in patients who are older or even in younger patients that have severe diminished ovarian reserve. If we don't see any follicles growing and the estrogen is not rising, there is no point trying to go to retrieval because you really need to ripen and mature the follicles to have a good chance of being able to retrieve a mature egg. The second reason we might suggest canceling the cycle, and this is a conversation between the doctor and the patient, is when we think we can actually do better and we don't think that the patient is going to meet their full potential. For example, if you have a patient who has 10 follicles at baseline and you got a follicle to grow, but it was one single dominant follicle. Well, that's not really the goal, right? Sometimes you can just have an off cycle and it's hard to understand why. But if we think there's a reasonable shot at you doing better and you're not meeting your full potential, it may make sense to just say, let's call it and let's stop the medications. And maybe we make you ovulate that one egg by giving you the trigger shot so that we can try to expedite resetting your cycle. And in 2 weeks, when you get your period, maybe we start priming with birth control, or we try a different protocol, a different approach. This decision is really individualized because some patients may be very motivated to go forward to have an egg retrieval for even 1, 2, or 3 eggs, depending on their timeline, their situation, their insurance coverage. The key is trying to make that judgment call of, do we think we can do better than this? So if someone has a lower baseline count of 4 or 5 eggs and there's 3 growing, that may be as good as it can possibly get. I mean, maybe a subsequent cycle will have a lower response. So in those types of situations, I counsel patients and encourage them usually to keep pushing forward. Remember, you want to see at least 2 mature eggs, and it would be great to have some small or medium-sized ones following closely behind. So you really have to make a judgment call and look at each patient case individually. The third reason why we might cancel a cycle before getting to retrieval is if a patient ovulates early. Because obviously, if they've ovulated and released a bunch of the eggs, you're going to get a suboptimal outcome at time of retrieval. The signs that this could be happening is when the estrogen level starts crashing and the progesterone level starts really rising. We usually can prevent this, and it's not that common for this to happen. Even medications that we're using, micro doses of Lupron throughout the protocol, or medications like Cetrotide or Ganirelix, these are called antagonists, do a really good job for most patients in preventing ovulation, but occasionally patients will ovulate through the medications. It's so important to be prepared for all of the possible outcomes before you start an egg retrieval cycle.